Hello and welcome to PT Kids Live with me, Daniel Woods, the director of PT Kids and a specialist children's physio. Welcome to our latest episode where we're going to be talking all about Selective Dorsal Rhizotomy, or SDR for short. Now, in physiotherapy we talk a lot about treating the primary impairment. We talk about treating the primary cause of something, and to make sure we're not just treating the symptoms. Now what that basically means is if you have back pain, as a physio it's really important we don't just treat the pain, we don't just treat the symptoms. We actually need to try and treat the thing that's causing the back pain in the first place. We might be able to take away the pain and give you some more range of movement, but unless you improve your posture and build some strength, the chances are that symptom's going to return. Now, for our children who have cerebral palsy, the primary impairment for them is the damage to the brain that's caused at or around the time of birth. Now, up to this point now, there is no surgery where we can operate on the nerves in the brain, or to correct the damage that has been caused to the brain at that time. One of the key issues that this causes in around 80% of people with cerebral palsy is spasticity. And I'll go on to define that a little bit more later on. But essentially what spasticity causes is a disruption between the messages sent from the brain to the muscle and the muscle to the brain. And what we then see clinically is tightness. Or what you'll see as a parent is stiffness in the muscles of your child. And it's this which is generally the primary impairment for children, particularly who are diagnosed with spastic type of cerebral palsy. Now, what the SDR operation allows us to do is to try to help correct this primary impairment in a way that we haven't been able to do before. The SDR procedure is a surgical technique and is a major procedure which involves cutting selected nerves in the lower spine to help reduce spasticity. The procedure usually involves a single level laminectomy, and a laminectomy is where the vertebra or the bone at the bottom of the back in the lumbar region is removed to expose or give access to the spinal cord. The procedure used at St. Louis Children's Hospital in America is described as being a minimally invasive laminectomy. Once this has been done, the sensory nerve rootlets that are judged to be responsible for causing spasticity are tested and removed. The procedure is selective because of the way that they test the rootlets, and they divide them into different sections and test them for an abnormal electromyographic response. It may involve removing up to around 80% of these sensory rootlets, and the motor rootlets responsible for voluntary movement are preserved. By removing these sensory rootlets, we can reduce the sensory input, which down-regulates the spastic reflex in the muscle, and will significantly reduce or eliminate spasticity. And as I described before, really goes into treating the primary impairment in a lot of our children. There are roughly 3 broad types of cerebral palsy. There's spastic type, dystonic type, and ataxic type. Now, selective dorsal rhizotomy is not going to have an effect on dystonia or dystonic types of cerebral palsy, or you may have heard athetoid or dyskinetic types being referred to also, which broadly fall into this category, as well as ataxic types. But for those roughly 80% of people with a spastic type of cerebral palsy, particularly for those who do not have any underlying dystonia along with their spasticity, SDR may be a very real consideration. The other important thing to recognise is that cerebral palsy is also often described by distribution as well. What I mean by distribution is the parts of the body that it affects. Cerebral palsy might involve total body involvement, hemiplegia, where one side of the body is predominantly involved, or diplegia, where the legs are predominantly involved. The SDR procedure is going to be particularly helpful for those people who are predominantly involved in the legs, those people who are described as being diplegic. or you may hear the term spastic diplegia also. You may hear some of the professionals that work with your child talk about all of these different terms, and it can be very daunting. And I think it's really important that if you're not sure about what any of these terms mean, please ask the professionals to explain, and I'm sure they'll be more than happy to tell you. It can be a minefield for professionals to understand the difference between athetosis and dystonia and spasticity and muscle tone and strength and how all of these things interplay. So I can only imagine what it must be like as a parent. So to try and put some of these terms in the simplest forms that I possibly can, spasticity is a resistance in the muscle to stretch when it's being moved. Spasticity is movement dependent, so the muscle needs to be moving or it needs to be stretched for spasticity to be felt. As the muscle is moved, there's a spastic reflex in the muscle that stops it and prevents it from being stretched, and this is often seen as stiffness. Dystonia, on the other hand, is an involuntary movement. It's where the contraction in the muscle is not controlled. It can cause the muscle to go stiff, it can cause the joints to twist or stretch in different positions, it can affect small muscle groups, or it can affect the whole body. Ataxia differs from those also because ataxia is to do with a difficulty in controlling voluntary movement. You might see it as shaky or jerky movements, but that's caused by damage to the brain or a part of the brain called the cerebellum. Now, another term you might hear talked about, which throws another little spanner in the works or will be cause for more confusion, I'm sure, is the word muscle tone. Now, tone is different to spasticity, although they're often confused. Muscle tone describes the state of readiness in the muscle for it to be able to move. So something with very high tone has an increased state of readiness in the muscle to move, and a muscle that's low toned has a decreased state of readiness in the muscle. Muscle tone is something that we all have, and essentially normal muscle tone is high enough to keep you up against gravity and stop you falling down in a pile, but low enough to allow your joints to move freely in the way that you want them to. If you have very high muscle tone, you'll tend to be quite stiff, and if you have very low muscle tone, you'll tend to be quite floppy. And muscle tone may fluctuate depending on if we're lying down or sitting or standing, or it's often affected by environmental factors such as if you're very cold, you may have higher muscle tone, or if you're very warm or hot, you may have lower muscle tone. If you're feeling nervous or anxious, you might have higher muscle tone, or if you're more relaxed, you might have lower muscle tone. So we all have various different levels of muscle tone. Muscle tone is normal, but it needs to be high enough to keep us up against gravity, but low enough to allow us to be able to move freely. Now, in our children with cerebral palsy, we often see increased muscle tone. So their muscles are in that increased state of readiness, they're feeling stiffer. This is different to spasticity, if not slightly overlapping in the concept. But if we think about spasticity as being movement dependent, and tone, we have tone when we're resting, we have tone when we're moving. That's the key difference between the two. Having a good understanding of the different types of tone that your child has, the different spasticity or dystonia, is going to really help you understand whether SDR is something that's going to be appropriate for your child. Now, some of the other terms that may lead you to confusion when we're talking about who may or may not be appropriate for the SDR operation are the terms GMFCS and GMFM. We are good in the medical world at trying to confuse and complicate things for ourselves. These two may sound similar, but they are fundamentally very different. The GMFCS is the Gross Motor Function Classification Scale. This is a scale that's basically used to describe how much movement or how much independence a child has who has cerebral palsy. Because cerebral palsy is such a broad spectrum of a condition and it affects children in all manner of ways, often two children who have the same diagnosis as, say, for example, spastic diplegia, the way in which they move and the things they're able to do for themselves may be very, very different. So the GMFCS, Gross Motor Function Classification Scale, is used to quantify that movement. The scale is measured on 1 to 5, where 1 is the children with the highest level of independent movement skills, running, jumping, hopping, walking, and 5 is the other end of the scale where children are much more dependent. Each level very broadly describes a different level of movement skill. Now don't confuse that with the GMFM. The GMFM is a gross motor function measure. What the GMF is it's a standardised assessment of movement skills in children with cerebral palsy. The GMFM is an assessment tool that physios use that helps track and monitor children's functional movement skills over time. There are roughly 2 different versions of the assessment. You'll either hear of the GMFM 66 or 88. What that basically means is the GMFM 66 measures 66 different movement activities, and the 88 is a longer version measuring 88 different movement activities. Essentially what this assessment will do, it will allow your physio to track and monitor your child's functional movement skills, and it will also help to place them on a percentile relative to other children with the same GMFCS level as them. So to try and give you an example of that, to try and help describe it a little bit better, I did an assessment on a young man who has spastic diplegic cerebral palsy, and he would be described as a GMFCS level 3. Now, a GMFCS level 3 describes children who walk using a handheld mobility device in most indoor settings, and they may climb stairs holding onto a rail or with supervision or assistance, and these children will use wheeled mobility or wheelchairs when travelling for long distances, and they may self-propel themselves for short distances. I performed a GMFM 66 assessment with him, where he scored 44.97, and 6 months later I retested him on the same GMFM 66 assessment, where he achieved a 46.5. The GMFCS level hasn't changed from a level 3, but his GMFM score, or his score on the assessment, has improved from 44.97 to 46.5. Very broadly speaking, children will tend to stay within the same GMFCS classification, but children do have the ability, with the right input, to improve their GMFM scores. So we know what the SDR procedure is, and we've tried to discuss a little bit about what all the different terminology means, and we understand why a child might be put forward for the SDR operation to help reduce or eliminate their spasticity. So who might it be appropriate for? And I think at this point it's really important to say that all children are really different, and you should seek some professional support from those people who you know, like and trust, and from those people who know your child really well. I'm going to very crudely describe some of the inclusion criteria for the surgery here in the UK, but that said, what you'll probably find is there's a broader inclusion criteria if you look to have the surgery abroad. And of course, here in the UK even, there are differences in criteria for those children who will qualify to potentially have the surgery under the NHS or at one of the NHS provision centres, as compared to those children and families who still choose to have the procedure in the UK but choose to do it privately. So those children who this surgery is potentially the most beneficial for are those children with a diagnosis of spastic diplegic cerebral palsy, children who have a GMFCS level of a 2 or a 3, children above the age of 3 and below the age of 9, children who have mild to moderate weakness underlying their condition. And here's another great, really important one too, which sometimes gets missed off, is children who have the ability to comply and cooperate with the post-op rehab that they're going to require after the surgery. Some important factors which may mean that the surgery is not appropriate for your child would include hip dislocation or significant hip subluxation, if your child has fixed muscle contractures that are not flexible, if your child has a significant scoliosis, and the surgery is not recommended for those who have an acquired brain injury. Children will also have a brain scan, and if there's significant damage to the motor cortex or the part of the brain that controls movement and posture, unfortunately SDR is unlikely to be suitable for them also. There are a number of centres that would say that if your child has underlying dystonia hiding behind their spasticity, that they wouldn't believe that they would be a good candidate for the surgery either. But, as I've described, There will be a difference in inclusion criteria from various different centres. I certainly know children who have had SDR who have been classed as a GMFCS level 1, but also a level 4 and 5. I've worked with children who have some underlying dystonia, some mild underlying dystonia, who've also had the SDR procedure. The SDR procedure is certainly available to people over the ages of 9 in various different places, particularly abroad. So if it is something that you're seriously considering, then I would recommend you take a really good look at all the different providers and all the different options. Some of the major centres in the UK you might wish to look at would be Alderhay, Bristol, Great Ormond Street, Leeds and Nottingham, all with different consultants and different neurosurgeons, and all will have a slightly different approach. And of course the main pioneer of this surgery, going back 31 years, is Dr. Park at St. Louis in America. He's really been at the forefront of developing the technique, making it more selective, making it less invasive, and helping produce long-term studies and long-term outcome measures for children who've had the procedure 20 and 30 years down the line. As of course, for a long time, SDR was not part of NICE guidelines and it was not recommended as a procedure under the NHS. Although through research and greater understanding of the procedure, it is now recognised in the NICE guidelines as a treatment option for the management of spasticity in children with cerebral palsy. But of course, there are other alternatives to managing spasticity in children, and there are another variety of different treatment modalities that should be considered. Botox injections can be used as a way of managing spasticity. The Botox injection is a chemical which acts by blocking the chemical signal between the nerves and the muscle that cause spasticity and cause the muscle to contract and feel tight. Botox injections can be placed in the specific muscle that's causing a difficulty or the muscle that's tight. And the effect of this is probably going to last about 3 or 4 months before it eventually wears off. So this is usually a short-term solution. Because the other important thing to consider is that Botox has a diminishing effect the more times that you use it over a lifetime also. So it should generally be used sparingly. I generally believe that if a child with diplegia responds really well to having Botox, that it probably means that they would be a good candidate for an SDR procedure. Children might also use baclofen to help with tight muscles. This could either be taken orally as medicine, or they might have an ITB pump fitted, intrathecal baclofen. Just about managed to pronounce that right, I think. Baclofen is essentially a muscle relaxant, so it helps to reduce stiffness in tight muscles by helping the muscles to relax. I suppose the thing to consider is that where Botox is very specific, is that you inject it into a specific muscle that you want it to work on. Baclofen is not targeted in the same way and has a global effect across the whole body. That means if your child also has low muscle tone in some of their other muscle groups, such as in their core, or if perhaps they struggle with their head control, or perhaps if they struggle with their swallow and managing saliva, because baclofen affects all parts of the body, it's also likely to have an effect on these weak areas also, potentially making them more weak. And some families also report that their child may be more sleepy or have less energy or get tired much more quicker when they're using baclofen because of this relaxing effect. But that said, I've seen it used in small doses and it's made a really big difference to children who have muscle spasms or cramps, and it can be really successful in helping to manage pain. Another potential option for children is to have orthopaedic surgery. Children who have tight muscles can have them lengthened, tendons can be lengthened and relocated. Orthopaedic doctors can alter the angle of the hip joints by doing things called femoral osteotomy, and I've certainly seen some very successful multi-level orthopaedic surgeries where children have been able to achieve much greater range of movement, and then that's then had a really good effect on their functional skills afterwards also. The thing to consider here is that, as I talked about earlier on, we're treating symptoms perhaps rather than primary impairments, and while spasticity is still evident, it may go on to further affect the muscle later down the line, and that muscle would be at risk of becoming tight again because of the effects of spasticity. I think you'll find the more you come to research all of the different techniques, and I would definitely recommend that you go out there and look at alternatives rather than just having one solution in your mind, is that there's going to be pluses and minuses of each. And between you as a family and the professionals you work with, it's up to you all as a team to balance out the pluses and minuses of each to then decide what's going to be the best route for your specific child. If you're interested in having your child put forward for an assessment for SDR, it's going to be really important to consult your orthopaedic surgeon or your orthopaedic consultant. And I am also hearing cases now where your local physio can refer into the spasticity management clinic, where SDR can now be discussed as a method of managing your child's spasticity. If your child does end up going for an assessment for the SDR procedure, they will go on to have quite a rigorous physiotherapy assessment. During that assessment, the physio is going to be looking at things like spasticity, strength, selective movement, goniometry, so looking at the range of movement in the muscles. They're going to do a GMFM 66, and hopefully you now know what that is. Most children, or I'd probably say all children, will go for some gait analysis, and that might be 3D gait analysis. They'll also need to have their hips and spine x-rayed, and they're likely to want to have an MRI scan done also. All of this information can be then used to link your child to the inclusion criteria, and as a whole team they'll try to decide what's the best thing for your child. So what have been some of the long-term reported outcomes of children who have had the SDR operation? Long-term studies are now reporting that children present with an immediate reduction in tone and long-term reduction or elimination of spasticity. Children are presenting with greater range of movement, so a reduction in their stiffness, and more movement in the joints and muscles. And also they found statistically significant increases in a child's GMF score compared to children who have not had SDR. Some other reported findings are also that children are complaining of pain much less, and that children are reporting and families are reporting an increase in the quality of life of that child. Now, at the risk of sounding a little bit biased, I wanted to talk a little bit more about the impact of therapy on children who've had SDR. Compliance and cooperation with therapy is a really important part of the inclusion criteria. The SDR is going to remove spasticity to give your child a greater potential for movement, but it's only in the engagement of a really solid therapy program and having a really strong plan for rehab that children will then go on to realise that potential. You probably hear people talking about the blank canvas, and I do think this is a great analogy because your child is now going to have to relearn movement patterns. They're going to have to learn to strengthen muscles that they've never used before or never been able to use before. They're going to have to work on their posture. They're going to have to work at increasing their mobility, and they're going to have to work really hard and be taught how to perform new movements. To give you an idea of the therapeutic commitment that children need to have in their post-SDR aftercare, the recommended amount and frequency of physiotherapy, as recommended by Dr. Park at St. Louis, is that in the first 6 months after their discharge from hospital, children will need an hour of physio 4 to 5 times per week. In the next 6 to 12 months, they're going to need an hour of physio 3 to 4 times per week. For the next 12 to 36 months, they'll need an hour of physio 3 to 4 times per week. This is the level of commitment to therapy that will be required for children to reach their full potential. I, like I'm sure you do, will read the headlines and read the newspapers which contain articles about children who have had the SDR operation. And certainly to the untrained eye, it may come across that the SDR is in some way a cure. I would sincerely love for this to be the case, but as I'm sure you will understand and appreciate, it's not quite as simplistic as it is sometimes reported. Is the SDR operation going to give your child greater potential for movement? Yes. Are they going to have to work for it? Also yes. Over the last 8 years, I've worked with over 50 families who have had the SDR procedure. And those families that are the most successful are the ones that have a very clear, consistent, persistent plan for therapy. That will include therapy at home provided by a physio, school staff being on board and having a movement program at school, families being committed to help the child being more mobile around the home and providing opportunities for therapy at home. even in secret or functional ways. And when it comes to those secret ways of getting therapy in, I also see children who have some kind of physical recreation hobby that will have therapeutic benefits, such as swimming or horse riding or trike riding, bike riding, dance or frame football. You're going to want to make a really clear plan about how you can fit all of these things into your lifestyle and into your home life and into your new routines. I guess what I'm trying to stress here is that if you are looking at the SDR procedure, try not to think about it just as a procedure, as an operation. Do consider the post-op therapy too, and think about it as a commitment to a minimum of a 3-year plan to maximise the effectiveness of your child's surgery. I would like to consider myself as an advocate for the SDR surgery, particularly for the right type of children. And over the last 8 years that I've been working with a whole variety of children and families who've had the SDR procedure, we've certainly seen some really remarkable outcomes. Around 25% of the children that I work with every week are children who have had the SDR procedure. I really hope this recording has given you a little bit more information about who, where, when, what and how the SDR procedure might be appropriate for. I would absolutely love to hear from you if you've got any further questions or anything you still are not quite sure about. If you're unsure whether SDR is an option for your child, if you'd like to know more about getting your child ready for an SDR assessment, if you'd like to know how you can work with your child pre their operation to help them get the best out of it, or if you're looking for a team of therapists who can help with post-SDR rehab, would really love to hear from you. Please leave us a comment, or you can drop me an email at office@ptkids.co.uk, and we're also on Twitter, Facebook and Instagram with the handle @PTKidsUK, and we use the hashtag TeamPTKids, where our mission statement is to have a dream, make a plan, work the plan, and don't quit. And when we do those things, that's when our children reach their full potential. Thank you so much for listening, and I can't wait to hear from some of you guys.